This deliberation is going to go into more depth than we've been able to in previous research, but when we've talked to Londoners before, one of the things that we note from some of the independent research is people are often shocked to learn just how little information is actually shared. So stuff that people often think should be routinely shared, when they learn that it isn't, and it isn't available to people like Stuart to provide help, that's a bit of a shock. I think one of our problems, though, as policymakers, is to say, well, if we want to respond to that and make sure that information is available when it's needed, how do we do that in practice? And I'm sure you've already started to unpick. There are lots of people involved, and so lots of choices. Remember, we're talking now about care to you as individuals, and so this is about personal information. We know it's you, and we know things about you. But care is being provided by teams of people, and each of them plays an important and different role in you getting the care that you need. Staff in those teams need to know about you, but people only need to see relevant information. And joining things up doesn't mean necessarily letting everybody see everything, though you might be absolutely fine with that. Reminding you what Murat said, when we do make care available, when we make information available, there are a whole range of things other than the computer system that mean that people just don't go wandering around looking at information because they fancy it. So there are set things like the law, people's employment contract, people's specific access rights, whether that's to be, they've got a card that gets them into the room where the paper records are, or whether that's that they've got a smart card that allows them to get onto the computer system with their login details. And underpinning a lot of that, registered professionals have particular obligations. And if they're found to have contravened those, there are really serious sanctions. As an example, in the east of England, over in Colchester, a healthcare assistant was found to be essentially just looking through records because that person was interested. We can't legislate and create foolproof systems. But what happened in that case was, because it was on a computer system, you could spot. It was 29 times that person had inappropriately accessed records, and as a consequence, they lost their job, they were struck off, they ended up being taken to court and fined. So these systems are not foolproof, but there are a range of sanctions and conditions that try and make access to information secure. But in all of that, there are still a whole range of benefits and some concerns. So because misuse can be spotted in a computer system in a way that it can't with paper, that particular person who was looking inappropriately through records was spotted. That's a benefit of bringing information together electronically. But when you take all of these different fragments and bring them together in a central system, it's harder to cross-reference fragments all over the place. If you bring data centrally, expert hackers will have a go at that. And that's a reality, and we're asking you through this process to play off with these hard trade-offs. Do we say that's really, really too problematic, that people will try and hack that information, and so we'll leave it fragmented and we deal with the consequences of having unsafe care? Or do we say that the balance of risk means that, we will do what we can to safeguard that information, but it's more important that we bring it together? These are the things we need to understand what you think about. Importantly, though, currently in London and across the country, because there are so many different organisations that are all independent, they do different things. We don't have consistency. So we need to understand from you what feels right. Murat's already talked about roles-based access control, and we want to spend some time with you now to understand what that means to you. In some places, they make choices where there's no differentiation. Everybody sees everything. In others, they create lots and lots and lots of different roles, 50 to 60 different roles. We need to understand what you think about that. But as you do discuss it, keep this in mind. Whilst you might think theoretically, technology can be ultimately and infinitely configured, it's still a human decision to say, is that person in this role or that role? And do they get to see this information or that information? That's a human decision. It's not about the technology. And so keep in mind that when that human decision happens, the more roles that you want us to configure, the more complicated it is and the more time it will take. And so really draw your attention to this balance of trade-offs. If you want lots and lots of differentiation in the roles, that's quite a complicated thing, and it might take us a long time. And in the meantime, we're saying to you, we think there's a lot of information that is required for safe care that's currently not being shared. So please bear these things in mind when you think about roles-based access. And that's really where we need your guidance. What feels right in who sees what and how much differentiation?